On 4th of September 2023, at Naraina Medical College and Research Center, Kanpur, there was this PU exam of students admitted in MBBS 2022 batch. This you are seeing is the anatomy paper 2 part 2. The exam was of 3 hour duration and the maximum marks allotted to this question paper was 50. Now, the first question, which is actually a structured clinical question of 3 subparts of 5 marks each, that makes it 15 marks. This pattern of question paper is according to the Atal Bihari Vajpayee Medical University of Lucknow, to which this college is affiliated. Question number 1. A sportsman, while playing basketball, sprained his ankle. He complained of severe pain on the lateral side of his right ankle. So what ligament is injured? Now, to solve this question, actually you need to know about the ankle joint and its clinical and applied aspect, because they are talking is about the lateral side of the ankle joint. So on the lateral side, there is anterior and posterior talofibular ligament, also a calcaneofibular ligament. Because they are mentioning it that he is sprained his ankle and has severe pain on the lateral side. And during a sports injury, the common site of sprain in an ankle joint is the lateral side. Even the fracture of the lower end of the fibula also can happen, because the common position in which a person falls is plantar flexion and inverted foot, because the range of inversion at this subtalar joint and tibiotalar joint is more than eversion. So inverted and plantar flex foot is a common position in which a person falls down and sprains the lateral side of the ankle and leads to tearing of this most commonly injured ligament, that is anterior talofibular ligament, which they have asked in the question. So the simple answer is, what ligament is injured? Anterior talofibular ligament. Next is, what other ligaments could be injured? Simple, I just told you the other ligaments here, the posterior talofibular and the calcaneofibular ligament. They also can be injured. What bone can be fractured? Because all the 3 ligaments here are actually attached to the lower end of the fibula, that actually is the lateral malleolus, that can also be fractured. So what bone can be fractured is the fibula at its lower end. That is all. I believe not more than 3 to 4 minutes are required to solve this question. So that's why I emphasize, while solving a clinical question, you need not give much time to this. You don't have to fill up pages. Just be precise, whatever is being asked, and that's why I say this also is very scoring. Next, question number 2 is, write short notes on, again 3 questions, 5 marks each, gives 15 marks. First one here is muscles of the second layer of the sole. Remember that the second layer of the sole is made up of hybrid muscles, means both intrinsic and extrinsic muscles, right? So the intrinsic muscles here are the lumbricals, the 4 lumbricals, out of which the medial one, the first lumbrical, is unipinnate. Then second, third and fourth lumbricals are bipinnate. And these lumbricals are actually arising from the tendons of flexor digitorum longus. So that also is a muscle here. And the flexor hallucis longus is also a muscle here in the second layer. And to straighten the pull of the flexor digitorum longus, which actually pulls the toes or flexes the toes downwards and medially, right? So to straighten the pull and to make the toes flex vertically towards the plantar side, there is an accessory muscle that is called flexor digitorum accessorius, which is also called quadratus plantae according to the International books. So this muscle is also a muscle of the second layer of the sole. Out of these, the long flexors, the flexor hallucis longus, flexor digitorum longus, they're coming from the back of the leg and they are innervated by tibial nerve. However, out of the four lumbaricals, the first lumbrical, the unipinnate one, is innervated by the medial plantar nerve, while the lateral three lumbaricals are innervated by the lateral plantar nerve, and even the flexor digitorum accessorius or quadratus plantae is also innervated by main trunk of the lateral plantar nerve. Right? This much is enough. You can also describe the actions and need not to write the origin and insertion. Well, if you know it, there is no harm. You can write the origin insertion also. This might give you some extra marks. Question number 2b. Relations of the first part of duodenum. This I have taught you in detail. Remember, the duodenum posteriorly is related by the gastroduodenal artery, common bile duct, the portal vein, and above to that is, remember, the artery of Wilkie, the supraduodenal artery of Wilkie. Don't forget to mention that also. And of course, the rest of the relations, you can mention them. The details are given in the book. Then development of interatrial septum, a super important, very important question from embryology section. You need to prepare this before going for the exams. Then ultra short questions where you have to write actually less than 100 words. So this question number 3, 5 subparts, 2 marks each. That makes 10 marks. First one is direct inguinal hernia. So remember, you have to describe the Hasselbalch's triangle here, first of all. And then that is being divided by the medial umbilical ligament into 2 parts, medial and a lateral part. So direct inguinal hernia comes out through the Hasselbalch's triangle either medially or laterally to the medial umbilical fold. So there will be differences in the structures forming the hernial sac. This also you have to emphasize. Remember, on the medial side, there will be the conjoint tendon, which will not be present as a part of hernial sac when it descends from the lateral side of the Hasselbalch's triangle. And cremastic fascia will be present as a part of hernial sac when the hernia will descend down through the lateral portion of the Hasselbalch's triangle. And this comes out through the superficial inguinal ring, which actually is a triangular opening. And this hernia will be palpable medial to the pubic tubercle. Question number 3b is congenital dislocation of the hip joint. This is important, and I believe I taught you this. So this congenital dislocation of hip joint is more common than any other joint in the body at the time of birth. So what happens is that the upper margin of the acetabulum is deficient or is less developed sometimes. So what happens is the head of the femur slips upwards onto the gluteal surface of the ilium, due to which the child, when starts walking, will have a lurching gait. And of course, the Trendelenburg's test will be positive in this. I think I taught you that how to help this, like if it's guessed or diagnosed early, right, in the infancy, then the mother is actually asked to carry the baby on the waist with the 2 thighs abducted on the side of her waist. This actually will help to settle the head of femur into the acetabulum and will give time for the upper margin of the acetabulum to develop, right? So prolonged abduction of the thighs is one of the conservative means of settling this. Question number 3c is developmental anomalies of the uterus. There are lot many anomalies of uterus given in the book. You can read it from there. Then 3d, microscopic differences between small and large intestine. Very important question. It's given there in a tabular format in your books. Same way, you can also write it down here. The differences in the walls of Kirk ring, that's plica circularis, the differences in the size and concentration of the villi, the differences in the arrangement of solitary and aggregated lymphoid follicles, the differences in the intestinal glands, presence or absence of Peyer's patches, presence or absence of Brunner's gland, concentration or the density of goblet cells, the differences in the longitudinal muscle coat, which is in the form of Taenia coli in the large intestine. Villi are absent in the large intestine. Brunner's are a feature of duodenum present in the submucosa. Peyer's patches are maximally present in the ileum. Hostrations is also a feature of large intestine, which although is not a microscopic feature. So you can mention all the differences here. Then writing about tips, that is transjugular intrahepatic portosystemic shunt. This procedure is done in case of portal hypertension. So in extreme condition, when there is a lot of bleeding from the esophageal varices or hemorrhoids, or you can see the caput medusae, splenic engorgement, all this can be helped with these tips. So here a balloon catheter can be passed through the internal jugular vein on the right side, reaching down into the right brachiocephalic, superior vena cava, right atrium, inferior vena cava, hepatic veins, and there into the parenchyma. From there, this balloon catheter can reach to dilate the branches of the portal vein. So in short, it can create a shunt. It can open up the blocked passages or narrowed passages. It can dilate them. And that's how it can create this portosystemic shunt within the parenchyma of the liver. Right? So that is tips. Now the MCQs. Question number 4. The first MCQ. Branches from the celiac trunk supply all of the following structures except diaphragm, the central tendon, esophagus, the cardiac end, duodenum, the first part, pancreas, the tail end. So the answer here will be the diaphragm, the central tendon, right? Because this is supplied by the inferior phrenic artery. That's the first branch arising from the abdominal aorta at the level of T12, right? It's a paired arteries. So it supplies the undersurface of the central tendon of the diaphragm, right? Then cardiac and the esophagus is supplied by the left gastric artery branch of celiac trunk. Duodenum, the first part, is supplied by supraduodenal artery of Wilkie, which is a branch from common hepatic artery, then gastroduodenal artery, then superior pancreaticoduodenal artery, all are branches from the celiac trunk. Pancreas, the tail end, of course, it's supplied by splenic artery and especially the arteria pancreatica caudalis. So splenic artery also is a branch from celiac trunk. So answer here is A. MCQ number 2. Which statement is false regarding the gastrointestinal tract? Throughout the length of the small intestine, the diameter of the lumen keeps decreasing from proximal to distal. This is correct statement because in the small intestine, duodenum has the widest caliber and the terminal portion of the ileum is the narrowest, right? So diameter keeps decreasing from proximal to distal. This is correct. Then throughout the length of the small intestine, the length and density of the villi keeps decreasing from proximal to distal. This also is correct. Then throughout the length of the large intestine, the diameter of the lumen keeps increasing from proximal to distal. Now this is a wrong statement and that's why this is the answer here. Remember, in the large intestine, cecum has the maximum diameter and in fact it's one of the organ which is more wider than its length. The breadth of cecum is more than its length, around 7.5 centimeter. I guess its diameter, around 6 centimeter its length. Similar is the case of pons and pituitary and also prostate. So remember this formula of PPP plus C. 4 structures: pons, pituitary, prostate, and cecum. All these structures are more wider than their length. The D option says that throughout the length of the intestine, the number of goblet cells in the lining mucosa keeps increasing from proximal to distal. This also is correct, of course, because as the food propels down into the length of the GIT, it keeps becoming hardened. The reason is the water is being absorbed. So the more harder the stool becomes, the more amount of mucus it requires to be propelled, right? So in the lower portion of the large intestine, the mucosal glands, that means the goblet cells, keep increasing in density. MCQ number 3, which structure lies deep to the left paraduodenal recess of the peritoneum? Inferior mesenteric artery, inferior mesenteric vein, left testicular artery, left testicular vein. I guess you know the answer to this. It is inferior mesenteric vein. Remember, it passes deep to this paraduodenal recess, which is a common site for internal hernia. So, while releasing the hernia, giving an incision here, the surgeon has to be cautious of not injuring this inferior mesenteric vein, which actually ascends above and terminates into the splenic vein. MCQ number 4, which of the following structures is not seen in a transverse cut section of thorax passing through the third thoracic vertebra? I have made a short video on this. That's shorts. I'm attaching the link. You can watch that video. Options here are right and left brachiocephalic veins. What they're asking is not seen. Remember, not seen. And the level is third thoracic vertebra. So the right and left brachiocephalic veins, left subclavian artery, left recurrent laryngeal nerve, thoracic duct on the right side of the esophagus. So third thoracic vertebra means the upper portion of the superior mediastinum, means behind the upper half of the manubrium, right? So there you will find the right and left brachiocephalic vein, especially the left brachiocephalic vein crosses the upper half of the manubrium sterni posteriorly. Left subclavian artery, because you know the arch of aorta lies behind the lower half of the manubrium. So the branches from the arch of aorta, they'll be in relation to the upper half of the manubrium. That is the level of T3. So left subclavian artery you're going to find there. Left recurrent laryngeal nerve, of course it's arching from below to this arch of aorta, so and it's ascending up to reach towards the larynx. So of course this also you will find there. The D choice is thoracic duct on the right side of the esophagus. This is a wrong statement because thoracic duct no doubt you will find there in the superior mediastinum, but in the superior mediastinum it lies on the left side of the esophagus. Remember, in the inferior mediastinum, that's posterior mediastinum actually, where this thoracic duct lies on the right side of the abdominal aorta, where this thoracic duct lies on the right side of the spine. At the level of T5, it crosses from right to the left side, and in the superior mediastinum, it continues to ascend onto the left side of the spine, or you can say it's the esophagus. So it is present on the left side of the esophagus in the superior mediastinum, and it even crosses the thoracic inlet to reach up to the transverse process of the C7 vertebra on the left side, where it arches and even becomes a content of the carotid sheath. Remember this. On the left side, thoracic duct is also a content of carotid sheath in the lower portion. So it bends down and opens at the junction of left internal jugular and left subclavian to drain into the left brachiocephalic vein. So the answer here is D. Question number 5. Which of the following structures is not seen in medial relation to the superior vena cava? Firstly, they're asking is not seen, and the structures are in medial relation to the superior vena cava. So which is not seen in medial relation to the superior vena cava? You have to guess this. Ascending aorta. Of course, it is in medial relation because SVC is on the right side, draining into the right atrium, and ascending aorta lies on the left side of superior vena cava. Brachiocephalic artery. Now, this brachiocephalic artery is branch of the arch of aorta. So, this also will be on the medial side, that is towards the left of the superior vena cava. Then right vagus nerve. Now this vagus nerve in the superior mediastinum is actually running on the sides of the trachea, which lies in central position, which is actually in medial relation to the superior vena cava or towards the left of the superior vena cava. So this right vagus descends onto the right side of trachea or esophagus in the lower position. So all the three options A, B, C actually are seen on the left side of superior vena cava, which is actually the medial relation of superior vena cava. Lastly, you're seeing is right phrenic nerve. This will be the answer. Now this right phrenic nerve from C3, C4, C5 spinal segments descends down onto the anterior surface of this muscle called scalenus anterior, and it then crosses the thoracic inlet, accompanying an artery along with it, and that is pericardiophrenic artery. So both phrenic nerve and pericardiophrenic artery descends down, crossing the thoracic inlet and runs onto the right side of the superior vena cava, running down on the right side of the fibrous pericardium, descending down, crossing the diaphragm through the central tendon, that's the opening for the inferior vena cava, along its right side. It will reach down to participate in the celiac plexus. So that's the course of right phrenic nerve. So remember that right phrenic nerve will be related to the right surface of superior vena cava, that is in lateral relation to the superior vena cava. Correct? Now MCQ number 6. Which two muscles together form a sling or a stirrup beneath the middle of the sole? Tibialis anterior and peroneus longus, tibialis posterior and peroneus longus, flexor digitorum longus and peroneus longus, tibialis anterior and peroneus brevis. There is a small video I have made and I have attached the link. You can watch it. Well, the answer here is tibialis anterior and peroneus longus together form a sling below to the mid of the sole, and this sling actually is important because it helps to maintain all the four arches of the foot: the medial longitudinal, lateral longitudinal, anterior transverse and posterior transverse. Very important point. MCQ number 7. Which statement is correct regarding accessory saphenous vein? It drains into the short saphenous vein. It communicates to the long saphenous vein via a direct perforating vein. It drains the posteromedial cutaneous area of the thigh. It drains the posterolateral cutaneous area of the calf. So remember that it drains the posteromedial cutaneous area of the thigh. Answer is C. Just to remind you that while reading option B, where it says it communicates to the long saphenous vein via a direct perforating vein, actually in the thigh, there is only one direct perforator vein which communicates the long saphenous vein with the femoral vein in the lower portion of the adductor canal. So it's not this accessory saphenous vein there. MCQ number 8. Muscularis mucosa is thickest in which part of the GIT? Esophagus, stomach, small intestine, large intestine. So remember that muscularis mucosa is thickest in the esophagus because it's vertically placed portion of the GIT in the posterior mediastinum, and it's closed, like the lumen is closed all the time, except only when the food passes through it, then only it opens. Otherwise, the lumen of the esophagus remains closed. So, to grip the food being passed to the esophagus, the role of muscularis mucosae is a little more in esophagus. Question number 9. Duct of Bellini in kidney is another name of collecting tubules, collecting ducts, PCT, DCT. So you should remember that duct of Bellini is actually the collecting ducts which open at the renal papilla, that is the apex of renal pyramids opening into the minor calyces. And each of these collecting ducts, they actually collect urine from lot many collecting tubules, also called junctional tubules. So, duct of Bellini is actually the collecting ducts. MCQ number 10, which is the last MCQ. Gubernaculum helps in descent of the testis. That's true by all of the following factors except contraction of the gubernaculum. Gubernaculum helps to dilate the inguinal bursa. This is true. It provides a continuous pathway for the descent of testis. This also is true. Remember, the gubernaculum is attached to the lower pole of the testis, and the other end, the lower end of the gubernaculum, is attached to the labium majus in case of females, because it also helps in descent of the ovaries. And in males, it's attached to the lower portion of the scrotal sacs. So it actually acts as a torch bearer during the course of descent of testis. With the progressive increase in the size of the embryo, the gubernaculum does not undergo a corresponding increase in length. This also is very true, because remember that gubernaculum is not a contractile tissue. It simply retains its size, but because of the growth of the body, there is differential shortening in the length of the gubernaculum, right? So that's how, as the body keeps growing, testis keeps descending, and the path which it follows is the path directed by the gubernaculum. So option number A, where it's mentioned as contraction of the gubernaculum, remember that it is not a contractile tissue. So the answer here is A. And that's all in this question paper.